Hello, my name is Dr. Daniel Kantor, and I'm the president of the Florida Society of Neurology and the medical director of Neurologique, an organization dedicated to patient-centered care, education, and research. I wanted to summarize what we've been hearing at the American Academy of Neurology annual meeting in New Orleans for the past week. We've heard a lot about MS from the point of view of treatment of MS, but also from the point of view of what we understand about multiple sclerosis. What we're starting to understand more about multiple sclerosis is different populations. We've seen some data that you may have heard about the Kaiser Permanente experience in California, where it looks like perhaps we have even more MS in African Americans than Caucasian Americans. We're seeing the type of MS that we see in Hispanic Americans as well. We're also learning more about potential triggers for multiple sclerosis. We've even seen some information about a controversial topic called CCSVI, or chronic cerebrospinal venous insufficiency. So we're learning more about MS itself. We're learning more about it immunologically. What is the role of the T regulatory cells, of the B cells, of the different types of lymphocytes? We learn that from basic science, but we also learn that from the medications and our success with treating MS. Let's talk about our success. We have on the one side disease-modifying agents or disease-modifying drugs, and right now the only thing we have are the currently FDA-approved medications and drugs in development. We don't yet have something that's an alternative treatment. We have talked in the past about low-dose naltrexone or about LDN. You just heard some information about CCSVI or about opening the veins, but all we have that's proven are the disease-modifying agents. On the other side, what we have is we have information about symptomatic treatments. Symptomatic treatments don't only mean symptomatic drugs. We use yoga, tai chi, breathing exercises, relaxation therapy. We look at visual imagery. Then we have medications that are pharmaceutical medications as well as ones that are complementary and alternative. You've heard something about omega-3 fish oil, and actually in a well-designed clinical trial, they looked at people who received omega-3 versus placebo for 6 months, and then were added interferon beta 1a subcutaneous 3 times a week, or Rebif. And so then you had people who were treated on Rebif plus placebo versus Rebif plus omega-3. There was no difference in the arms at any of those points. Interestingly, there were some trends that maybe some of the MRI measures were a little bit worse with the omega-3, but that was just a trend and not statistically significant. I like to look at the potential for side effects in trials, and actually there was less myalgia in the interferon beta 1a plus omega-3 versus the interferon beta 1a plus placebo. So if any of you have had success with not having too much of the myalgias or the muscle pain with interferons and you're using omega-3, that would be interesting. I don't think people should run out and take omega-3 because we don't know how safe it is in general. But what we do know is that the best way of getting omega-3 is to actually just eat fish. We've heard about other treatments that I call neurofunctional enhancers. A neurofunctional enhancer is a treatment that empowers you. Instead of saying we don't know if you're going to be better or worse in 20 years, we can say that in the next month to 2 months we'll know whether you respond or not to a treatment, and then if you come off, you may feel that you actually did better on it and you can go back on. The idea is how quickly they work and how it really enhances your function if you have a neurological diagnosis. The first example of this is a medication by a company called Accorda. The medication is called Ampera or dalfampridine. It's an oral medication taken every 12 hours, and it's called the walking pill because it's FDA approved for helping with gait with MS. Then in terms of affect, which is how we display our moods, mood is what we're feeling inside, and affect is what we're displaying. There's a medication that's FDA approved for pseudo-bulbar affect, and that medication is called Nuedexta. It's also fixed dose dextromethorphan, so like in cough syrup, plus low doses of quinidine. We saw some results from a trial of duloxetine, and we saw more of those results at ECTRIMS, at the European Committee on the Treatment and Research in MS. That conference we went to last year, and we'll be going again this year to Lyon, France, so make sure to follow us there. And That treatment was for MS pain, so the central neuropathic pain of MS, and duloxetine orally did better than placebo. There's an ongoing trial called PRIME looking at different doses of dextromethorphan plus quinidine versus placebo for MS pain as well. So go to neurologique.org and go to the research tab, and you can find research that's near you. It's all searchable, and you can find what's going on clinicaltrials.gov. Now, we also heard about rescue treatments. So rescue treatments are that arm in between, and when you're getting too much of it, it may mean that that disease-modifying agent isn't quite the right one for you. In terms of rescue treatments, we have FDA-approved IV solumedrol or methylprednisolone, usually taken 3 to 5 days with or without an oral prednisone taper. We have intramuscular or subcutaneous ACTH, adrenocorticotropic hormone, which not only helps stimulate the body to make its own natural steroids, it also has an effect on melanocortin, which may be why we actually don't see necessarily the bone health problems and the apoptosis or the programmed cell death that we see with corticosteroids like methylprednisolone. Off-label, we sometimes use IVIG or IGIV, intravenous immunoglobulin, or plasmapheresis, which is sort of cleaning out the blood. Low-dose oral prednisone or oral steroids looks like it's actually worse for MS and may lead to more relapses. We saw some more data on high-dose oral steroids as well. So as you can see, in the world of MS, we're learning a lot more all the time, and we hope to come back to you at lots of different conferences and expand our scope beyond just the American Academy of Neurology, ECTRIMS, the European Committee on Treatment and Research in MS, and the one that's coming up next, the Consortium of MS Centers, or CMSC. We hope to get beyond. There are meetings in other countries and other parts of the world, and as we learn more about MS in Asian populations, there's something called PACTRIMS, and there are lots of other opportunities for us to get back to you. I will also be, without MSWorld, but I will be at the European Neurological Society, so ENS, in Prague this year, and I hope to report to you about things that are going on. I'll personally be presenting a platform presentation on people with pseudobulbar affect, PBA, after a sports concussion that went away. Person was crying uncontrollably after a sports concussion in American football. I will also have a poster on fingolimod, also called Gilenya, the oral medication for MS, on a patient who I started it on where his heart rate was 40 beats per minute. It's kind of low, and then it went up by 1 point to 41 instead of dropping down. So because of that, I thought it was interesting enough to put out there in the medical literature, and I guess the organizers of the meeting felt the same way. Even in between conferences, I want to be able to answer your questions, so please write me letters and write me questions. You can go to facebook.com/neurologique, twitter.com/neurologique, youtube.com/neurologique. You can go to our blog, which is at neurologique.blogspot.com, and then you can watch some live and recorded town hall meetings at ustream.tv/channel/neurologique. Of course, you can always send in your questions to MSWorld and address them to me if you want my response. You can also go to MS Foundation and you can address questions there as well. And we'll try to share them across the multiple platforms so that we can all work together in this MS community, in this MS world. But don't forget who the center of the MS team. The center of the MS team approach rule is you. It's you, the patient, the person with MS. Thank you so much for joining us.